that we bring live from UITM Bertam, Pulau Pinang. Rabiatul Adawiah binti Abdul Rahman graduated with Master in Health Sciences Physiotherapy from the Faculty of Health Science, University Technology Mara. She completed physiotherapy, Honors of Physiotherapy from UITM Puncak Alam as well. Recently, she joined Faculty of Health Science as lecturer in Bertam campus. She has been active in research activities and participated in clinical services, looking at rehabilitation management of children with disabilities at the Faculty of Medicine, Sungai Buloh campus, UITM. Her research interest includes pediatrics, neurorehabilitation, with special interest in children with TBI. She has presented and published papers in this industry. Rabiatul Adawiah, are you here? Are you ready for the session?
Inshallah.
Inshallah. Ladies and gentlemen, please welcome Rabiatul Adawiah binti Abdul Rahman. Rabiatul, the platform is yours.
Okay, Assalamualaikum warahmatullahi wabarakatuh and good afternoon everyone. Okay, thank you to the moderator Mr. Afiq for the brief introduction on my background. Okay, first of all,
Most welcome.
I like to thank all the webinar committee's member for giving me this opportunity to share some knowledge with the others. Okay, so today I'm going to focus on the pediatric population. So the topic will be cognitive impairment and functional mobility in children with TBI. So let me share my slide first. Okay, can you see my slide? Okay.
Yes.
Okay, so this is the topic that I'm going to share with all the participants. Okay, so this is the content of the presentation. Okay, we're going to look at in terms of different aspects in terms of TBI. Okay, so let's move on the definition first. Okay, so TBI can be defined as a non-degenerative acquired brain injury, okay, resulting from a bump, blow, or jolt to the head, or it can be penetrating head injury that disrupt normal brain function. So the keywords here are the non-degenerative, it does not involve any pathological process, and it also caused by the external physical force, okay, which lead to disruption in the normal brain function. Okay, so the figure here show the several types of the brain injury. But what we're going to focus for today's session is traumatic brain injury that caused by the external physical force. Okay, let's have a quick recap on the brain anatomy and function. So as we know, the brain is the largest component in the CNS, our central nervous system, which containing about 100 billion multipolar neurons. And each area of the brain, okay, has a primary responsibility that contributes to our ability to function, which control all the system in our body. Okay, so the brain can be divided into several areas. Okay, the first we have a cerebrum, which comprise of largest portion and associate with higher mental function. And we have a diencephalon, okay, for the processes and sensory input, cerebellum and brainstem. Okay, cerebellum for the muscular activity and also balance, and brainstem for the regulation of visceral activities. Okay, when we come into lobes, okay, lobes of the brain. Okay, in general, we have four pairs of the lobe. Okay, in front of our head, we have a frontal lobe, responsible for the motor control, okay, problem solving and speech production. So this is where the Broca area is located. Okay, and at the lateral aspect of the head, we have a temporal lobe, okay, responsible for the auditory processing, language comprehension, and also for the memory. Okay, so let's look at on the top of the head, we have a parietal lobe. Okay, it is responsible for the touch, okay, and body orientation and sensory discrimination. And the last one, we have a pairs of the occipital lobe at the back of our head. Okay, the primary function is for the visual reception and also visual interpretation. Okay, and then beneath of the cerebrum, we have a cerebellum and brainstem that I have just mentioned on the previous slide. Okay, so let's move on the overview of TBI in children. Okay, when we look at in terms of data, okay, approximately 3 million of children experience TBI yearly. So 3 million is a large numbers, okay? So when we look at in terms of age range, okay, so there are two age range in pediatric population which most likely to sustain TBI. Okay, the first one is 0 to 4 years, and the second one is adolescent, okay, 15 to 19 years. Okay, when we look at these two age range, okay, the mechanism of the injury will be slightly different that I will show you in the next slide. But in general, when we look at the causes of the TBI, okay, so the main cause that lead to the TBI are falls and road traffic accident. Okay, but then when we look at in among the children, okay, more than 50 children who survive from the injury, okay, they will experience unfavorable ataupun or we call it as a long-term impairment, okay, or for the post 6 months after the injury. Okay, so like I mentioned, the pediatric population, okay, it is wide range of in terms of age. Okay, so when we look at for the infants, okay, for example, infant, okay, the cause mostly due to inappropriate childcare practice, okay, which lead to the accidental or abusive head trauma, which is something comes from the caretaker or parents. Okay, and then when we look at the adolescents, the mechanism or the causes, okay, which lead to the TBI is slightly different because the activities at this age, okay, it is different from the infants and also from the toddlers. So during this age, they are starting to involve with the contact sports like a rugby, okay, hockey or football, and they are start using the motorcycle as a medium for transportation, which expose them with the high risk for traumatic brain injury. Okay, so that is the difference between the two age range that I've shown on the previous slide. Okay, now we look at and focus on our country, Malaysia. So in fact, there is a scarce in terms of statistic for the childhood brain injury. But as we know that the main factors, one of the main factors of the TBI is road traffic accident. So in 2019, when we look at the report by the PDRM, so they have shown that, okay, the number of road traffic accidents is affected about 1.74% of the population for the entire country. And these numbers keep on increasing, okay, between a range of 10,000 to 20,000 cases yearly. It is quite large of numbers. Okay, when we want to reflect to the young population, okay, to our pediatric population, so the National Trauma Database Malaysia report that, okay, about 41% major trauma that caused by the RTA involved age range 5 to 25 years with the injuries to the head and neck, okay? So it relate or reflect to the traumatic brain injury. But in terms of numbers that we have seen, the mortality were decreasing in the past few years, which indicate an increasing of TBI survivors. Okay, one of the factors may be because of the improvement in our healthcare system and also technology that that help the patient to survive after the injury. Okay, now we look at the risk factor for TBI. Okay, so the first one is sport, okay, especially contact sport, okay, as you can see in this figure, like hockey, rugby. Okay, so for the adolescents, okay, they are actively involved in the contact sport, which is why they are more vulnerable to have a TBI. Okay, when we look at in terms of age, okay, children and elderly. Okay, in terms of children, we know that they are dependent on the caregiver. So anything malpractice or abusive behavior from the caregiver, okay, will lead to the TBI for this population. And we look at the sex, okay, males are more common, okay, as compared to the female. And the age for the highest risk factor for to sustain TBI is 15 to 30 years. Why? Because on this age, most of them are active in with the contact sport, and basically they are used the what we call transportation medium of transportation by using the motorcycle. So that's why they are vulnerable to get the TBI. Okay, so let's move on the classification system of the TBI severity. Okay, when we talk about the severity, so there is a classification system that are used by the medical profession, okay, to classify where is the severity for particular patient. Okay, so the severity is ranged between mild to severe. Okay, we have three common classification system here. The first one is a Glasgow Coma Scale. Okay, and then we have a loss of consciousness duration. The last one, we have a post-traumatic amnesia duration. Okay, as you can see here, okay, mild TBI, also called as a concussion sometimes. Okay, so the range of the GCS is between 13 to 15, with the LOC, okay, less than 30 minutes, and PTA less than 1 hour. Okay, and the rest, I think the rest you can read from this table. Okay, so this is how the severity of the TBI is being classified. Okay, so as we see the GCS for the pediatric, so there is a certain component which is in terms of description, it is more detailed. Okay, the component is remain same. Okay, because it still evaluate the three aspects, which are verbal response, we have an eye opening, and motor response. But in children, it is quite detailed. Okay, for example, we see the verbal response. For them to get 5 scoring of the GCS, so they need to display appropriate smile and coo. This is for the child less than 20 months. Okay, and then appropriate phrases and words for the child 2 to 5 years, and oriented and converse, okay, for the children over 5 years. Okay, so basically what we can conclude from here. So for every single scoring, it is basically depend on the developmental milestone for the children at the specific age. Okay, so based on the Glasgow Coma Scale (GCS), so there is an outcome that we can expect from the patient. Okay, if the patient present with the vegetative state, okay, less than 5 GCS score, there is not much we can do for the patient. Okay, for the severe 5 to 8, so child is conscious, but they are need 24 hours supervision because of multiple impairment. Okay, it can come from the cognitive aspect, or it can come from the physical aspect. Okay, for the moderate 9 to 12, so what we can expect is the child eventually they will become independent in ADL, but at the same time, okay, so they still have the impairments following the TBI. And the last one for the mild, okay, this is a good outcome. Okay, good recovery is expected, and basically the child is able to reintegrate into the normal social life with minimal persisting sequelae. Okay. Okay, we want to know why is TBI in children different as compared to adult. Okay, children brains are in constant state of change and is still developing. The maturation process is keep on going. Okay, so during period of rapid growth, especially the first 5 years of life, okay, the brain may be more vulnerable to damage. Okay, the reason is the first one is the skull is less rigid in infant. As we know that the suture that connect between the skull bone is remain open. Okay, so this suture, okay, function as a joint, which allowing for a small degree of movement in response to mechanical stress. Okay, and the second one is larger head proportion as compared to the body. So consequently, the likelihood for the head being hit in a pediatric trauma is higher as compared to the adult. Okay, once they have a larger head, surely they will have heavy leg as compared to adult. So that's why there is the impact will be dynamic, and the head acceleration due to external force during the trauma or accident. But they are still in the process of developing and acquiring new skill. Okay, following injury, children must not only meet the challenges of recovery, okay, but also ongoing challenges of development and maturation. So the effect will be long term, okay. So TBI injury is a chronic condition process rather than one-time event, even though the event that lead to the TBI only once, but the process, okay, the recovery will take time, okay, because the symptom may change and unfold over time, okay. So there is many symptoms that may appear even though there is a 2 years post TBI. Okay, now we move on factors affecting the outcome of pediatric TBI. So basically there are three main factors. The first one is injury related factors. Okay, type and severity of injury. Okay, so increase the severity of TBI will put the children with more longer and greater persistent deficit. Okay, pattern and extent of primary injuries. Okay, if they have present and severity of second injury like a cerebral edema. Okay, and severity of clinical parameters like a death or coma. Okay, the longer death or coma, the greater deficit and impairment that they will have in the long term. Okay, the second factors is patient related factors. Okay, age at injury. Okay, especially if they have or they sustain the TBI within 5 years of life, so they will have a greater impact and longer persistent effect because of this injury. And then we have a premorbid issue, psychological, okay, developmental achievement at the time. And we also have a family and psychosocial characteristic that will influence the outcome of the pediatric TBI. Okay, so the last main factors is treatment related factors. Okay, time to rescue from the TBI. Okay, time to trauma, care and type of care given. And we can see here we have a time to rehabilitation, okay, type, intensity and duration of rehabilitation. So this is where we see our role as a physiotherapy in improve the outcome of pediatric patient. Okay, now we move on the effects of TBI in children. Okay, as we can see here, okay, according to Brain Injury Association of America, so they have listed the wide range of impairments that can be due to TBI. Okay, so it can be from the physical, cognitive, or emotional. Okay, as you can see, for example, physical, okay, the children might have a motor coordination problems, okay, balance, sometimes a spasticity or paralysis. In terms of cognitive, they might have a slowness of thinking, limited attention span, okay. But what I want to highlight here, there is the impairment can be a wide range, means that the children might have several impairment in different aspects. Okay, so this is the effect on that particular patient. Okay, now we move on the effects of TBI on family. Okay, we need to remember, okay, the children is depend on their caregiver and family. So whatever happen to the children, so it will affect the family indirectly. Okay, so the first one, increase the risk for psychological symptom in family. Why? Because TBI is not a congenital condition. Okay, so the parents, especially because of their children is born normally without any impairment or problems, so it is difficult for them to accept for what happened to their child. Okay, so the family will go through grieving process, okay, in order to accept the situation, and they also will start to feel frustrated, okay, when the recovery is become slow and the child start to miss expected developmental milestone. At the same time, they will also have issue in terms of financial impact, because we know that the TBI will require a high cost, okay, in terms of medical expenses. So they need long-term monitoring, okay. They need long-term monitoring from the hospital and medical expert, okay, in order to monitor the progression and recovery. So sometimes, okay, the parents, especially mothers, need to resign from the job, okay, in order to give a full attention to the child. So this will give a financial impact for the family. And then we need to know that a sibling also is a part of family, because of this because of the child in the family having the TBI. So the parents start to give a lot of attention for that particular patient. So the sibling surrounding them might start to develop jealous, okay, anger, and create some behavioral issue because of lack attention towards themselves. So in this issue, what they want and what they need is the social support, counseling for them to go through all these events. Okay. Okay, now let's focus back into a cognitive impairment. Okay, so increased severity of the injury will put the children more vulnerable to attention deficit. So what is attention? Okay, attention is a information processing capacity of an individual to focus on the particular task. So if they have limitation in the focusing attention, so they will affect on how the child to grow and interact effectively with their surrounding, whether it is people or the environment surrounding them. But we need to remember, okay, sometimes cognitive impairment, it is not something that we can observe with our naked eyes. Okay, sometimes it needs a thorough assessment from the medical expert. Okay, so this cognitive impairment may not be noticeable to others, which may cause anxiety or frustration towards the patient. Okay, now we look at a bit detail in terms of attention in children. Okay, as I mentioned, attention deficit are common existing impairment in children with TBI. So when we look at this population, they are presented or they are characteristic with short sustained attention. Okay, reduced information processing speed. They are take time in order to understand a simple question or information or instruction from the others, and they have a difficulties in performing dual tasks, especially in attention demanding tasks. For example, they need to walk while talking. So that is example of dual task in children with TBI. Okay, but then we need to remember, if they present with the attention deficit, it can severely disturb their working performance. Okay. Now we look at the functional mobility. Okay, even though after they are able to walk, okay, even though they are able to ambulate independently, okay, in terms of efficiency, okay, efficiency and quality of the functional mobility is being disrupted. Okay, as you can see, balance and walking velocity remain disrupted even though for the long term in the children with TBI. Okay, about 70% of children with TBI have some balance deficit and limitation in walking ability, cause the child to become more dependent on their caregiver and less participation in social life. So basically, they need to perform a safe walking in order for them to become more independent and participate more in a community setting. Okay, as you can see here, so these are the characteristics, okay, for the gait in children with TBI. So their gait is slower, okay, reduce in step length, increase in step length, variability. Okay, when we look at the balance, okay, there is a decrease in terms of balance performance in this population. Okay, now we look at the connection between cognitive and functional mobility. Okay, children commonly encounter situations in which they must perform cognitive and motor tasks at the same time. Okay, for example, responding to verbal instruction, okay, while manipulating object in standing or walking position. So this situation may be complex and challenging to the children with TBI because they are presenting with both, okay, attention deficit, and they also having information processing speed deficit. So when we look at the previous study, they have shown that dual tasks, okay, when they are performing two tasks at the same time, they cause the reduce in gait speed and step length, okay, but increase step time and step length variability, which show that they are vulnerable to the dual task interference. Okay, TBI survivors are prone to have gait instability and repeated head injury if they have if they have both, okay, motor and also cognitive deficit at the same time. And there is evidence that presented a significant association between the cognitive and motor function post-TBI. Means that if the patient have a cognitive impairment, it also will impact the functional mobility to this patient. Okay, so these are what happened, okay, when they are asking to perform dual tasking, okay, when they are performing two tasks at the same time. Okay, because of the dual task interference, their gait becomes slower. Okay, reduce step length, reduce cadence, increase step length, and increase stride time. Okay. So what we can do as a physio, what we can help for them in order to prepare them to enter the community setting, especially in unpredictable environmental. So we can include the dual task training into the rehabilitation program. Okay, so what is the dual task training? Okay, dual task training is basically we add on additional tasks. Okay, for example, if our conventional therapy currently we are doing the gait training, okay, just walk. So today for the dual task training, we add on additional tasks. Okay, for example, we ask the patient, okay, walk while counting backward. So walk while counting backward is considered as a dual task training. Okay, when we look at the previous study, okay, they demonstrate that children with TBI more vulnerable to dual task interference, okay, as compared with the healthy control. And then these findings suggest that, okay, the importance of dual task training as a part of the rehabilitation component for children with TBI. Okay, and when we look at the study that conduct dual task training intervention, okay, they show that dual task training improve gait parameters and balance in patients with neurological condition. Okay, study also show the safety, feasibility, and short-term benefit of dual task home-based rehabilitation program in order to improve balance control in patients with acquired brain injury. So then why should physiotherapists consider cognition? Okay, why we should consider cognition component in our rehabilitation? Because the gait require attention. Okay, we need some amount of attention in order to perform a gait, in order for us to walk. Okay, impaired cognition reduce attentional resource, which compromise gait stability. So this is what happened in children with traumatic brain injury. Okay, motor impairment after brain injury increase the amount of attention required for single task ambulation, leaving decreased resource available for a secondary task. Okay, maybe for us as a healthy individual, walking is a simple task. Okay, simple activity that we can perform without any thought. Okay, but then it is become more complex. Okay, after the injury for that particular patient, that they need to pay certain attention in order to just perform the walking alone. Okay, the association between gait and executive function increase if gait task is challenging. Okay, normal gait pattern is altered, and what we can see here, decreased cognition ability, for example, ability to pay attention for the particular task, it can lead to increased towards fall risk. Okay.
Excuse me, Rabiatul, sorry to interrupt. We have another 3 minutes before Q&A session. Thank you.
Okay, so for dual task assessment tools, okay, in a physiotherapy aspect, okay, so we are focusing on divided attention. So divided attention is ability to perform two tasks at the same time. Okay, so important role in working in multitasking and changing situation in order to prepare the patient to be able become independent in the community setting. Okay, and then the cognitive task that we add on, okay, during the dual task training is given as a distractor. Okay, we want to challenge the brain capacity to share the cognitive resource between walking and secondary tasks. Okay. Okay, so how we want to calculate whether the dual task is cause deterioration in terms of performance when the patient is walking. So this is the common equation that we will use, okay, to calculate whether the secondary task is cause the deterioration. Okay, so sometimes not sometimes deterioration of the gait or the dual task performance we can refer as a dual task cause. Okay, so this is the formula that we use, and it is represent as a percentage. Okay, so it's okay. I will not elaborate because of the time constraint. Okay, so these are the example of the secondary task selection. Okay, so for example, if you want to do the dual tasking, so the single task will be gait or balance activity, but you can choose any of it to add on as a additional or secondary task. Okay, you can choose whether you want your patient counting backward, but it's depend on the patient ability and stage of recovery on that time. Okay, so these are the example of dual task training. Okay, so for example, if you want to do the balance activity, okay, you can choose semi-tandem, okay, eye opens as a single task, and you can add on spell words forward as a secondary task. Okay, so you can measure the dual task cost while performing all this activity. And this is the example for dual task training. If you want to do the transitional activities, which is gate activities, okay, you can see in this table. Okay, so how does decreased attention affect mobility? Okay, impact in divided attention, okay, which is ability for us to perform the two tasks at the same time. It may reduce the adaptability to challenging environment, because we know that our nature of environment, there is a lot of obstacle. Sometimes we need to face the uneven path. Okay, community environment is dynamic and predictable. Sometimes when we are going to mall, there is a crowd, so there is a lot of attention that we need to put in, okay, in order to avoid and to face all these obstacles. And then more challenging to safely and effectively maneuver around obstacle while being or cognitively engaged in a secondary task. So the brain will be challenged to prioritize between two tasks. Okay. Okay, poor insight or awareness for us may lead to poor prioritization while dual tasking, that will lead to falls, okay, at the end. Okay, so as a conclusion, from my presentation today, so we can see that TBI in children can lead to long-term impairment and disability in different aspects. And then the ability to walk while simultaneously attending to other people, okay, tasks or environmental cues is a very important and crucial for them to become independent in the community setting. Then it is recommended that we as a physio, okay, to include dual tasks, okay, as a part of our rehabilitation training, okay. But then, okay, in this population, there is a lot of research, okay, and that need to be conducted in order to look at whether it is efficiency, it is effective or not, okay. So I think that's all from me, okay. That's all, itu saja. Okay, thank you, Mr. Afiq. If there is any question.
Thank you, Madam Rabiatul Adawiah, for an informative session. We have a question from the participant. Azliana would like to know on what are the common equipment required for dual task training.
Oh, sorry. Okay, what are common equipment? Okay, when we talk about the equipment, okay, there are the equipment that is which indicate is a commonly used for the dual task training. We just need stopwatch, okay, to record the time for the patient to complete the task that we assign to them. Okay, in terms of another equipment, it depends on the protocol or the secondary task that we ask patient to do. For example, if you want your patient, okay, walking while carrying a cup of water, so then you need to prepare a cup of water. So it's simple as that. Okay.
Thank you, Madam